Arterial ischemic stroke is the most common stroke in children. And arterial ischemic stroke, there is AIS, occur due to infarct in a defined arterial territory, either due to thrombotic or embolic phenomenon. It presents with consistent clinical symptoms and signs depending on the territory involved. AIS is the most common mechanism in 53 to 85% case of stroke in children. The recent International Pediatric Stroke Study, IPSS, has identified at least one risk factor in 89% and presence of two or more risk factor in a 47% of ischemic stroke, arterial ischemic stroke. The IPSS group classify causes of AIS into following category: cardiac disease, sickle cell disease related arteriopathy, arterial dissection, moya arteriopathy, and other cause. They cause arterial ischemic stroke. Next. Greatest recurrence risk among the pediatric stroke is for a AIS. Among them, arteriopathy is the highest risk of recurrence. Childhood AIS is markedly different from adult in risk factor and presentation. Cerebral arteriopathy. Stenotic cerebral arteriopathy is identified as a AIS etiology in 60 to 80% of previously healthy children, and course of this arteriopathy is a stronger predictor of recurrent event of stroke. Moya angiopathy and sickle cell disease related to arteriopathy are the most frequent form of chronic intracranial arteriopathy in children. There are increasing reports of mineralizing angiopathy of lenticulostriate vessel and primary angiitis of CNS is rare in children. Focal cerebral arteriopathy, there is 30 to 40% of the children with AIS arteriopathy have a unilateral focal cerebral arteriopathy, FCA, characterized by unique form of arterial insult with unilateral focal stenosis of terminal carotid trifunction and characteristic monophasic course. Childhood FCA is suspected to be inflammatory vessel wall pathology triggered by infection, typical varicella infection. The recurrence occurs for a greater majority in the first 6 months after the index event, and hence aspirin 5 mg per kg per day is recommended for at least for 18 to 24 months with a further stabilization and regression of arterial stenosis, which help in preventing future recurrence. Stroke rarely recur when progression stenosis stops. Arterial ischemic stroke, common etiology. Cardiac, there is a congenital cyanotic heart disease, congenital acyanotic heart disease, and cardiomyopathy. Acquired cardiac disease, there is a cardiomyopathy, rheumatic heart disease, infective endocarditis, catheterization, and cardiac arrhythmias. And hematological, there is an iron deficiency anemia, sickle cell anemia, thrombophilia, or prothrombotic state. Next. Cervicocephalic arterial dissection, there is a traumatic or non-traumatic suspect vessel wall defect in tribal trauma. Dissection of internal carotid artery result from blunt trauma to the vessel in the tonsillar fossa, commonly seen in pencil injury. Spontaneous dissection should be suspected in setting of acute infection. And cerebral arteriopathy, there is a idiopathic focal cerebral arteriopathy and transient cerebral arteriopathy. Post-varicella angiopathy and pertaining to vasculitis, including primary CNS vasculitis, systemic vasculitis, and infective vasculitis. Fibromuscular dysplasia, Moyamoya disease, Moyamoya syndrome, mineralizing angiopathy of lenticular straight vessel cause stroke in children. And genetic metabolic cause, there's a Fabry's disease, homocystinuria, and mitochondrial disorders, they cause stroke in children. And arterial anomaly like neurofibromatosis type 1, there is tuberous sclerosis, phase syndrome, posterior fossa anomaly, hemangiomas, arterial anomalies, cardiac anomalies like coarctation of aorta, and eye anomalies. And certain stroke in children, there is a cause is not known, there is an idiopathic stroke. So in case of stroke, has the face drop, you should see four things. Has the face droop? Can they lift both the arm, or is there any drip of one side? In the speech slurred, and do they understand you? And time is a critical and timely medical care. So it is a medical emergency. Symptoms indicative of stroke were neuroimaging indicated when the new onset of focal seizures, new onset of severe headache, altered mental status, including transient loss of consciousness or behavioral changes, new onset of ataxia, vertigo, or dizziness, and sudden onset of neck pain or a neck stiffness, and witness acute focal neurological deficit, which has since resolved. So these are the indications for neuroimaging. Clinical features and the difference between anterior and posterior circulation stroke based on a specific territory. Anterior circulation stroke due to this middle cerebral artery territory, and stroke is most common. So in case of anterior cerebral arterial territory and middle cerebral arterial territory, the clinical features are hemiparesis, aphasia, visual field defect, altered mental status, convulsion, aphasia, amnesia suggest cortical involvement. While in case of posterior circulation stroke, and most common, there is a posterior cerebral artery territory, and it involves vertebrobasilar system and all brainstem stroke syndrome. And most common is posterior cerebral artery territory, and the clinical presentation of this stroke due to this posterior circulation stroke is ataxia, vertigo, diplopia, and vomiting. Next. In case of anterior territory, the weakness of the lower limb, there is a contralateral hemiplegia with or without hemiplegia. While also in case of anterior or middle cerebral artery stroke, there's a loss of voluntary control micturition with contralateral hemianesthesia or contralateral homonymous hemianopsia. And also they presented with aphasia. While pertaining to this behavioral and memory disturbance, apraxia is present due to stroke due to anterior middle cerebral arteries. While in case of posterior cerebral artery stroke, the weakness of the lower limb, there's a sensory loss and pain movement and disorders due to thalamic involvement, and the loss of voluntary control of micturition associated with visual field loss, such as hemianopsia and quadropia. and cortical blindness. And there is no clinical symptomology signs due to behavioral memory disturbance is present in case of this posterior cerebral artery involvement. Next, brain stem stroke syndrome included under posterior circulation stroke. So in case of brain stem stroke syndrome, in case of midbrain due to Weber syndrome, third cranial nerve palsy with contralateral hemiplegia. While in case of Pons, in case of Foville syndrome, there is a 6th to 7th cranial nerve palsy with contralateral hemiplegia. But in case of stroke due to medulla, it occurs in Wallenberg syndrome presented with ipsilateral cerebral sign, sensory loss over face, and bulbar muscle weakness, nystagmus, vertigo, then present due to involvement of inferior vestibular nucleus, Horner syndrome, contralateral loss of pain, and the temperature over the torso and limb. So there's a different presentation in a different syndrome due to brainstem stroke syndrome. In midbrain, there's a Benedict syndrome presented with third cranial nerve palsy with contralateral hemiplegia with tremor, rigidity, and ataxia on the opposite side. While involvement of these brainstem, the Pons, it occurs in Millard-Gubler syndrome presented with 7th cranial palsy with contralateral hemiplegia. But if there is a brainstem involvement of medulla in case of, so in brainstem stroke involvement, when there's a midbrain, in case of Benedict syndrome presented with third cranial palsy with contralateral hemiplegia, and also there's a tremor, rigidity, and ataxia on opposite side. But when there's an involvement of the Pons, in case of Millard-Gubler syndrome, presented with 7th cranial palsy with contralateral hemiplegia. But in case of involvement of medulla, in case of Desjardins syndrome, presented with ipsilateral 12th cranial palsy with contralateral hemiplegia with a contralateral loss of posterior column sensation. Next. In case of midbrain, there is a Perinote syndrome. There is an upward gaze palsy with pupillary light near dissociation and convergence, retraction nystagmus, and the lid retraction present in case of Perinote syndrome due to stroke in midbrain. Which are the investigation carried out in case of arterial ischemic stroke? There is AIS. First trial investigation, there is a CT brain with CT angiography, MRI brain with MRI angiography plus minus, and complete blood count, peripheral smear, cyclic test, ESR, and the blood sugar. NFT, RFT, urine routine micro, if needed, screen for infection. There is a retroviral serology, enteroviral studies, study for mycoplasma, varicella zoster virus titer, and coagulation profile. There is a PT and APTT, and cardiac evolution. There is a ECG with a prolonged lead to recording and echocardiography. So these all are first trial investigation in case of pediatric stroke. In second tier investigation to be done within first week after stroke, and lipid profile, serum lactate, transcranial or carotid Doppler, prothrombotic workup, there is serum homocysteine, factor V Leiden mutation, and methylene, tetrahydrofolate reductase, and gene mutation, and prothrombin gene mutation, lupus anticoagulant, APLA antibody, and prothrombotic workup, tests which are to be done after 3 months. There is a protein C, protein S, antithrombin 3 activated protein C resistance. Third tier investigation performed on an individual basis according to etiology of stroke. The metabolic workup, there is a ABG, serum lactate, serum ammonia, TMS, and urinary GCMS. And vasculitis workup, digital subtraction angiography, mitochondrial disorders workup, there is CST lactate and pyruvate, muscle biopsy, and genetic study, and leptomeningeal and the brain biopsy in case of suspected small vessel primary CNS vasculitis. So these are the investigations carried out in pediatric stroke. Neuroimaging is a mandatory in all cases in whom stroke is suspected. MRI brain is an investigation of choice in pediatric stroke. However, it is recommended that at least a CT brain with CT angiography is performed within 1 hour of arrival at hospital, and CT angiography is limited to intracranial part if there is evidence of intracranial hemorrhage, or from the vertex to nape if the CT brain does not show any hemorrhage. CT brain, it is an initial imaging if hemorrhagic stroke is suspected, and CT brain may be normal in first 12 hours in an ischemic stroke. More than 50% of CT brain done at time of presentation of child, the stroke is normal. CT brain is a good choice for pediatric stroke in an acute care setting where MRI brain facility is not available. It is also helpful in identifying mineralizing angiopathy of lenticulostriate artery by detecting calcification. And MRA, there is a magnetic resonance angiography should be done for a suspected case of stroke at a time of undertaking MRI. This should cover the aortic arch to the vertex in AIS and can be limited to the intracranial circulation in hemorrhagic stroke. Digital subtraction angiography is an ideal investigation of choice which help in detection of vasculitis, collateral blood flow, emboli within blood vessel, and aneurysmal anatomy. And it is useful investigation of choice in moya disease where puff of smoke appearance is made out. Also considered digital subtraction angiography in any child where next any etiology of stroke has not been made out. DSA, when there is the etiology is not made out, do DSA. And the treatment in case of stroke, there is an acute treatment and the long-term treatment. In acute phase, there is a supportive care, there is a stabilized airway, breathing, and circulation. Temperature and oxygenation should maintain normally along with avoidance of hypoglycemia and hyperglycemia. Next. In acute setting, relative hypertension is not rare, but must not be aggressively lowered except in following circumstances. In children who are otherwise eligible for intravenous thrombolysis, but in whom systolic blood pressure exceeds 95th percentile for the age by more than 15%, and hypertensive encephalopathy in a presence of end organ damage or dysfunction, cardiac failure, and renal failure. In case of stroke, with a feature of raised intracranial pressure to reduce cerebral edema is required to ensure adequate cerebral perfusion pressure. Swallowing should be assessed concurrently with the sensorium to decide about mode of nutritional support. Enteral, there is a oral, tube feeding, or parenteral. Next, after stabilization, physiotherapy and rehabilitation should be planned. Early mobilization is needed to decrease the risk of aspiration pneumonia, pressure sores, deep vein thrombosis, and contractures. Next, treatment of arterial ischemic stroke, AIS. In acute phase, there is a supportive care and antiplatelet therapy like aspirin, anticoagulant therapy like heparin or low molecular weight heparin, and recanalization therapy in case of acute thrombolytic therapy and mechanical thrombectomy. And the long-term management in case of stroke, there is a neuro rehabilitation and the seizures control in case of epilepsy by anti-epileptic drugs, and secondary prevention of stroke by antiplatelet drug. There is aspirin, clopidogrel, and dipyridamole, and anticoagulation therapy. There is a low molecular weight heparin and warfarin for secondary prevention of stroke. Specific treatment of underlying cause in case of stroke. Evidence regarding supportive therapy after stroke in children. Class 1 recommendation, there's a supportive measures for AIS should include control of the fever, maintenance of normal oxygenation, control of systemic hypertension, and normalization of serum glucose level. While in case of class 2 recommendation, treat dehydration and anemia in children with stroke. Next, in case class 3 recommendation, there is no evidence that use of supplemental oxygen is beneficial in children with stroke in absence of hypoxemia. In absence of clinical and electrographic seizures, prophylactic administration of antileptic medication in children with ischemic stroke is not necessary. In absence of additional data confirming its safety and efficacy, hypothermia should not be used in children with stroke except in context of clinical trial.